My goal is to cover the topic of mild cognitive impairment, which is a tricky subject and a controversial one as well. And hopefully I'll hit some of the highlights of our current knowledge and how this may transfer to the future and how it may help improve care. So what is the problem? Dementia is a huge problem. It's estimated that there are over 5.5 million Americans who have Alzheimer's disease or another dementia. It's also estimated that about 10 to 15% of people over age 65 have MCI, or mild cognitive impairment, in addition to those who already have dementia. About 10 to 15% of the people who have MCI will progress to Alzheimer's disease over a year. Over the lifetime, the estimated risk, if somebody has MCI amnestic form, which I'll discuss later, is about 50% or possibly even higher. There's no specific diagnostic test right now for MCI or Alzheimer's disease that we use routinely in the clinic, and there are no approved treatments for MCI. There are approved treatments for Alzheimer's, but all are symptomatic and none really alter the underlying disease course. And lastly here, screening for MCI or Alzheimer's disease for that matter is controversial, and I'll touch on some of those controversial points. I don't like to use the term dementia. It has negative connotations. The term that is now formally used is neurocognitive disorder. I like that term because it emphasizes that these are really brain disorders, and it de-emphasizes what many people view as being labeled as crazy, which is the connotation of dementia. So in terms of a neurocognitive disorder, there are two forms. Dementia represents a major form, and one of the new wrinkles to the definition is that in addition to cognitive symptoms, it also now recognizes different neuropsychiatric symptoms as being part of a clinical picture. It has to involve a decline from a previous level of functioning and interfere with day-to-day functional activities. The impairment has to affect at least two different domains, any combination of cognitive and or behavioral symptoms, and it has not explained by delirium or other psychiatric condition. So these are the core features of what we know as dementia, now referred to as major neurocognitive disorder. Now, the other form of neurocognitive disorder is what we call MCI, or mild cognitive impairment, what we used to call that, and this is mild neurocognitive disorder. For the purposes here with respect to Alzheimer's disease, it really does focus on just cognitive symptoms. It involves a decline from a previous level of functioning, but in contrast to the major neurocognitive disorder, daily functional activities are preserved, and one or more cognitive domains may be affected. The most common form of MCI involves just short-term memory, and this is referred to as the amnestic form. And this is the form that is often, but not always, a prodrome to Alzheimer's disease. There are other types of MCI where another single cognitive domain, such as language, may be affected, and this might be an early warning sign to a different type of neurocognitive disorder called primary progressive aphasia. And a third type, which is also fairly nonspecific, involves multiple cognitive domains, but collectively they don't significantly interfere with day-to-day functional activities. And the multiple domain form of MCI is really associated with many different etiologies. The new criteria that have been published are shifting our focus from the clinical signs and symptoms to what's going on in the brain. And we now know that the changes, amyloid in particular, begins accumulating decades before we see any clinical symptom. And so stage 1 is just amyloid. Stage 2, the MCI stage, is where we would have some tau protein deposits and neurofibrillary tangles that would disrupt brain cell function, causing early symptoms. And then finally, what's now the dementia stage, or stage 3, where you have a lot of accumulation of tau protein and a lot of brain damage that's occurred. So by the time what we are used to calling early Alzheimer's disease, it's really stage 3, and a lot of brain tissue has been lost due to those protein deposits. And here's kind of the schematic of this. Here we have amyloid deposits accumulating long before there's any signs of a clinical problem. Here we're just seeing the first signs of a memory problem due to tau protein accumulation in various parts of the brain, especially the hippocampus, and then finally stage 3, where they get a full-blown dementia. And so the graph I showed before really starts here where this dotted blue line is and goes to the right. And ultimately, what we'd really like to do is intervene in stage 2, where there are early signs and we can detect amyloid, but eventually we'd like to intervene in this process in stage 1. So what are the clinical diagnostic criteria? The formal criteria used for research require that the subject is concerned about cognitive decline in their memory or other cognitive domains. So they have subjective awareness, and this is a little problematic, as I'll get to in a minute. There has to be objective evidence of cognitive impairment on formal testing based on age and educational norms, and they have to have relatively preserved independent functioning in day-to-day life, although they may have some mild problems or need minimal assistance. Now, to revisit that first item, there's data from a recent study that was done in a neurology clinic that did routine cognitive screening, and they found of all the subjects that tested screened positive on the mini-cog test, only 29% of them complained of a memory problem, which means that 71% of the people who had a positive test on the screen didn't report a memory problem. And this really underscores one of the central problematic issues in this area, is that most of the people who have a problem aren't aware that they have a problem and therefore don't seek help for the problem. So here's a case just to illustrate the assessment process. A 67-year-old woman who comes in with a 3-year history of short-term memory difficulties. They were subtle initially, but they've gotten worse over time. She was concerned about them, so she quit her job. And aside from that, she really doesn't report any other cognitive symptoms, and she's doing pretty well for all instrumental activities of daily living. She's able to drive okay, manage money okay, and social interactions haven't changed either. No other significant medical history or psychiatric history. She doesn't take any prescription medications, negative family history. She has a bachelor's degree, drinks a glass of wine with dinner, does yoga on a regular basis. Her physical exam and neuro exam are unremarkable. Her routine lab studies are all within normal limits. And on cognitive testing, she misses, the only thing she misses on the MMSE is 3-word recall. So here she is. She has evidence of a memory problem. And she complains of a memory problem, and it's demonstrated on a testing. So where we are right now is either MCI amnestic versus early Alzheimer's disease. And the evidence so far would point more to MCI amnestic. But what can we do to help get more information about this? Well, if we give her multiple choice and she gets all 3 from multiple choice or category Q, then that would point towards something other than Alzheimer's disease. Whereas if she wouldn't remember any of them with recognition or with cues, then that would be a sign that would point more towards Alzheimer's disease. And then if we did an additional test, such as clock drawing, and saw this, then we would say, well, even if she's not functionally disabled, then we're moving from MCI amnestic to MCI multiple domain, and maybe it's just more a matter of a time before functional impairment. So seeing this, to me, would indicate that it was more likely that this person may be headed down the road to Alzheimer's disease, even if we don't call it that now. And obviously, a standard part of the workup is to get a brain scan. So here's an example of an MRI scan which shows classic textbook changes associated with Alzheimer's disease, which is hippocampal atrophy, outlined in red here. Now, very few patients have this level of atrophy, especially if they're in the MCI stage. And even if they did, it's not very likely that the radiologist would distinguish this from normal aging. And the fact is, there isn't a reliable way to distinguish what's abnormal in terms of hippocampal atrophy from what's normal based on the current subjective radiology reports. And if you're not actually looking at the scan, you're really dependent on what the radiologist sees and what they report. So unless there's something very obviously abnormal, it often won't be that helpful. Now, in contrast, there are brain imaging tests, namely an amyloid PET brain imaging test, that have been shown to be fairly sensitive and specific for distinguishing Alzheimer's disease shown at the bottom with the accumulation of amyloid deposits in the frontal lobe and parietal lobe compared to normal elderly where there's very little uptake related to amyloid brain deposits. We have several of these amyloid PET tracers available that have been validated and approved by the FDA. The reason we don't use them is because there aren't any treatments available that these would tie into, and insurance won't pay for them because of that. So here we have a test that's available that could be potentially useful for early diagnosis, yet we're not able to use them because the treatment side of things is lacking. So if we, for example, got this amyloid PET scan in this case that I just showed you, then we would refer to it as MCI with Alzheimer's disease, given that we've shown that there is amyloid in the brain and that she really is in the early stages of Alzheimer's disease. So just to summarize here, at the very top headline is that we need sensitive and specific tests, but even more so, we need disease-modifying treatments. We have potential markers for these disorders now that have been approved by the FDA and are available. What's holding us back is that we don't have disease-modifying treatments. And when we look at the evidence for screening, it really doesn't support it from an evidence-based point of view, but from a personal point of view, that may end up with there's some tension between what's evidence-based and what's personalized. So an example would be if somebody has prediabetes, you're not going to ignore it and say, come back in 6 months, and if it's gotten worse, then we'll call it diabetes. So some interventions, and especially lifestyle interventions, I think are well worth pursuing in the MCI stage, certainly recommending. A survey done of American neurologists a few years ago showed that the majority of neurologists did recommend lifestyle modification factors routinely in patients with MCI. And ultimately, we really need to pay more attention to prevention. And actually, primary care doctors, by addressing hypertension, high cholesterol, are really the front line for prevention. We just need to find more effective ways for intervening earlier in the disease course. And I'll mention here that the state General Assembly has just allocated money to expand a Alzheimer prevention registry throughout the state that will be based at Duke, but also involve UNC and North Carolina A&T. And finally, I think when we look at how medical care is provided now, patients with memory disorders just don't fit well in it. So I know I've covered a lot on MCI, and I'd be happy to answer any questions. Thank you very much.